So hi everyone, and welcome again to JOSPT Asks, the weekly chat where you, the audience, get your questions answered. I'm Clare Ardern, I'm the Editor-in-Chief of JOSPT, and it's really great to be chatting with you again this week. Today on JOSPT Asks, it's a pleasure to welcome Dr. Karin Silbernagel from the University of Delaware, which is the #1 ranked physical therapy program in the US. As well as teaching the next generation of physical therapists at Delaware, Karin also leads the very productive and clinically focused tendon research lab at the University of Delaware. We're also really fortunate to benefit from Karin's experience as a member of the senior editorial team at JOSPT. So there are few people better placed than Karin to help guide us through the best current research on Achilles tendon, and more importantly, how to apply that knowledge to our clinical practice. So today we're answering your questions on managing Achilles tendon pain. Welcome to JOSPT Asks, Karin.
Thank you. And I really appreciate that nice introduction. So I'm really looking forward to all the questions that people have.
It's going to be a great session. I'm so glad to have finally got you on the live stream. Let's jump straight into diagnosis to start with. And I'd like you to share with us how you approach diagnosing Achilles tendon pain. So someone comes in to see you at the clinic in Delaware. Where do you start?
So a lot of times where we start is often, we want to have the history of the injury and have the person really describing how they injured themselves, where they have pain, and the whole history. What I have learned early on, though, is to really quickly also have them point to where their pain is. Because I've been through early on, sometimes in my career, you get all excited and you think you're talking about the Achilles tendon, but they're pointing under their foot, like for the plantar fascia. So really establishing that we're actually talking about the same area, I think is really important. Then understanding what their issues are. And Achilles tendinopathy really has the typical signs. They have the morning stiffness, they have pain with activity, they can sometimes hard to walk down the stairs in the morning, but then they warm up, they feel better. So there's some very distinctive traits of Achilles tendinopathy. So we kind of go through that, but then fairly quickly, I want to go into some kind of clinical exam to really determine where the pain is. So it should be, if there's Achilles tendinopathy, there should be pain in the tendon when you squeeze on the tendon. So if they describe all these things, but there is no signs of pain in the tendon, then you really need to start thinking about other differential diagnoses. So I think pain on palpation, there are several clinical diagnostic tests that you can do, Royal London Hospital test and the painful arc. There are diagnostic tests, but all of those kind of relate to squeezing the tendon and see if there are any thickness in that area or if it's painful. The other test that we kind of do, just kind of for the next step too, is to really look at pain with hopping is another one that we do to kind of see if you can provoke it. Is it pain with that when you're provoking it?
And what about differential diagnosis? So you talked then about, that very typical pain when you squeeze the tendon, but if you've got some of those other signs and symptoms, perhaps not the pain when you're squeezing the tendon, what might be other things that you're looking for?
So really for differential diagnosis, we want to make sure that we don't have, we can divide Achilles tendinopathy up in mid-portion and insertional too. So people, depending on where it is, and people that have pain at where the tendon attached to the bone, to the calcaneus, a lot of times you can have other problem that is just not tendon related. Well, I guess it's tendon related, but not the tendon, like bursitis and other things. So you might want to look at that where it is. There's also sometimes people think that they have pain from the tendon, but their pain is not when you squeeze the tendon, but they have pain when you force plantarflexion. And a lot of times that is the posterior impingement of the ankle. So there are those things. We've had people coming in that think they're Achilles tendon, but then it turns out when if you load or squeeze the Achilles tendon, it's no pain. But if you load or resist flexor hallucis as long as you can provoke the pain. So all those tests that we can do to provoke the pain is really important too. And then it's important to think about, the tendon, we are so focused talking about Achilles tendinopathy, but the tendon ranges from attachment to the bone all the way up to the muscle. So you want to see, is the pain more in a muscle tendinous junction, or is the pain coming more from the soleus, which is a bit deeper than the tendon? So we sometimes go in then and do ultrasound imaging because we have that in our lab and we can look at those things as well.
Yeah, and I'm glad you bring up the imaging because that was my next question. Where or how are you using imaging and what sorts of things are you looking for and when in the diagnostic process are you using the imaging?
Yeah, so imaging is, I find very useful and exciting to have. But I mean, I think you can do the diagnosis and treat Achilles tendinopathy. Could you try? Oops, sorry about that. My watch talked to me. Um, I think that you can really do a good clinical diagnosis without having the ultrasound imaging. However, if you have ultrasound imaging, it's really nice to be able, if you do palpation and move around and those things, you can, and if you think, for example, the tendon might not be so tender, but it seems to be a little bit deeper, you can actually see if you squeeze the soleus, maybe there are some changes, or can you see if the soleus is affected, or there's a gastroc, is a muscle tendinous junction. We can also look at areas to see if it's insertional. Is it a big bursa inflammation? We can start looking at other differential diagnosis. And the nice part too is that we can ask the patient to move. We can get them into certain positions. And that's how we've seen sometimes if some people have an extra osteogonum in the back of the ankle, you can actually see that. And when that seems to be compressed, that's when the pain generation. So it's a nice visual tool. Like it's like looking under the hood of the patient, right? You can actually see the engines just from, not just from palpation.
And is imaging something that you only do at the first consultation, sort of in that initial diagnostic period, or is that something that you're going to use throughout your management? How do you bring imaging in, or how do you not bring imaging in?
Yeah, so our research group is working a lot on looking at various aspects of, we call it tendon health. And we think structure is one piece of tendon health, along with symptoms and function and all the other parts. And our research is really looking at, can we look at predictors and changes in tendon and tendon structure? One of the simple things that we're looking at is the degree of thickening within the tendon. So you can have an Achilles tendinopathy, normally you have like a straight thin tendon that is normal. But if you have tendinosis or thickening, you can see a part where the tendon gets thicker. And the degree of difference between the thickest part and the thinnest part is what we call thickening. So it's like the change within that tendon, because it should be evenly. And we've seen that that degree of thickening actually relates to symptoms. It seems to relate to the ability to recover. So that's something that we want to measure to kind of set the tone of expectations. We know that if we do that imaging and measure that every week, we're not going to see anything because it takes longer to change. So then you don't want to do the imaging every week and say, oh, it looks the same, oh, it looks the same. But I think right now we're following people every 8 weeks. I think is good if you want to follow up with the imaging. However, the imaging is also really good as a biofeedback, right? To look at, are you using the right muscles? Do you see changes? And for the recruitment. For example, the people have a lot of problems recruiting the gastroc and the soleus. Sometimes the whole movement of plantar flexion comes from flexor hallucis longus. So then you can actually use it as biofeedback. So I think it has a lot of various utility.
Nice. Now, the other part of or one of the questions that came through on Slido was about biomechanics and kinetics, and where in the assessment do those kinds of things come in? So where are you looking at biomechanics, where are you looking at kinetics, and how are you fitting that into your diagnostic picture?
Yeah, I think that's a great question. And I think we have, in a sense, maybe published the least amount of that from my research group. I think that we really are focused on a lot, and we have been, on the tendon and the tendon recovery. But one of the things I really want to emphasize is don't lose sight of being a clinician and looking at the whole patient. Our research are geared towards certain things relating to the tendon, but we always try to look at the whole person. I would say that I start with looking at the tendon, how that affects function. We're looking at the ankle to start out with. We've seen, for example, in the Achilles tendon ruptures, that usually the changes in compensation is the joint above or below. So we would assume the main thing around the ankle is affected by the knee and the foot. Some people have tried to look at how much the hip changes and hip weakness relates to Achilles tendinopathy or risk of Achilles tendinopathy. Not very good evidence to say in the group level that that is related. However, I would never argue that if you have a patient that has no control in the hip and you're looking at them and you're thinking that they're loading wrong, that on the individual level, I think those things are really, really important. However, I would say the evidence is it's not very strong. So, but we are always treating patients. We're treating the whole patient. So if you see some things that are maybe very weak, you might want to work at that at the same time. However, I do not think there is ever a possibility to fit a patient to the norms, right? None of us are normal. The normal is just an arbitrary different person. So I think you need to use your clinical test of evaluating weaknesses and those things, but then trying to look biomechanically and try to fit some kind of norm, I never do that.
Thanks. Good clinical tips. Now, you're in your lab, you're measuring things like strain and tendon stiffness. How do those principles fit into what you're trying to measure to try and get an idea of what's going on with this tendon? Cumulative strain on the tendon, how are you sort of putting all of these pieces together?
Yes, I think that's a really, really good question. And I think to really put it out for clinicians and things too, we are now known for we're doing elastography, and we're looking at mechanical properties through continuous shear elastography. And I think it's a very exciting area to evaluate mechanical properties of tendon, because tendon needs to transfer load between the muscle and the bone. That's what they're doing. And the better they are at that, the more efficient we can be. The interesting thing with mechanical properties is that the tendon needs to be strong and resisting force, but it also needs to be somewhat flexible, because it works as a rubber band. So when you load it, like you're running and the ankle goes into dorsiflexion, you load this tendon, right? And then it kind of rebounds just like the rubber band, and you can use that energy as your next step. So it's a balance between being flexible and being stiff. So that's kind of the problem with various tendons, and all different tendons have different kind of properties fitting them. So I think it's really important to understand how the healthy tendon, that you want a tendon to be healthy, to be very efficient. I mean, the clinical thing, and you've heard it before, Claire, too, that how I describe it is that you want, like if you have a basketball and you have good air in it, you can easily bounce it up and down. It doesn't take a lot of energy. But as soon as it starts to lose a little air and it's not as bouncy, you have to put more and more energy into that in order to get the same height of the basketball. And that's kind of what we see with a lot of things with runners. If you get good running economy, you have a really healthy tendon that you can bounce on to looking at, to use that energy. And we see that if you lose with tendinosis and tendinopathy, you change the mechanical properties. People actually, a lot of athletes describe before they have the pain that they're actually, they're not running quite as fast, or they don't feel like they can jump quite as high. And that probably relates to maybe the mechanical properties are changing before you see the symptoms. So we think it's really important to evaluate these mechanical properties from a research perspective. I also want to say, though, that it's difficult to do in a clinical perspective, right? So we have methods, and our methods is meant to kind of understand the research, and then we can understand how can you improve these mechanical properties with exercise and with loading, and then we can guide clinicians in how to do it. I'm not so sure yet that everybody clinician needs to test the mechanical properties, but we're trying to do it so we can get an understanding of how to best load or how to best generate the treatment.
Great. And I guess the other point perhaps to cover here is whether the mechanical properties of, say, the Achilles tendon is the same as the mechanical properties of the patella tendon or the lateral elbow tendon or the gluteal tendon. Could you give us a bit of an idea of mechanical properties of tendons more broadly, and then how they sort of the more specifics of the Achilles tendon?
Yeah, so I think first I want to say from clinician perspective, we call it mechanical properties, but mechanical properties can be various things. And we look at something that we call viscosity, which is a rate dependent property. And you can look at that difference between water and molasses, right? That's more of a rate dependent. We also look at what we call shear, but what most people look at when they talk about tendon, you're looking at the strain and the stress. And those kind of, what you're looking at that is like for if you pull a tendon apart with 2 kilos, how far can you pull the tendon apart, right? How much does it move? How much does it stretch? That's the strain. Versus stress is kind of how much load do you need to do that kind of movement. So we have various properties, but we call it mechanical properties from a clinician point of view. So when we're looking at these various properties, it's kind of understandable that we see, for example, we can look at viscosity goes down with Achilles tendinopathy, and shear modulus goes down. But we do see when we start looking at patella tendinopathy, we see differences. So when you start looking at tendon, and all these various tendons are meant to do different things, like you have longer, thinner tendons, thicker, broader tendons. So it's not that easy to assume that what you see with changes with injury and what's positive in one tendon might not be identical in another tendon. So I think that's important. People start reading all these things, you might start to feel that it's very, it gets confusing, and yes, it gets confusing, but it's because every tendon, you have to look at that and to understand what that means for that tendon. And I think that's what we are with mechanical properties today.
That's great. Thanks for a really nice overview of mechanical properties. And I'd like to move us to stick with the measurement topic, but look at some patient-reported outcomes. And so some of the tools that people might have read about when they read the literature is, I'm sure that people will be familiar with the Visa A that was originally developed in Australia. What are your favourite patient-reported outcome measures, and how would you use those in the clinic?
Yeah, so that's a great question. And I really appreciate too, I was want to say that you like to looking at talking about the various measurements that we do too, because you don't want to get stuck in only looking at the tendon structure. You want to have something that reports the pain. You want to have this broader. So the Visa A is the Victorian Institute of Sports Assessment Achilles questionnaire, was based on the one for patella tendinopathy. I think it actually is a brilliant questionnaire. It has some criticism, but it really asks, the first 6 questions ask about, do you have pain? Do you have stiffness in the morning? Do you have pain with walking? Do you have pain with hopping? You know, those kind of things, like exactly what our patients have problems with. And the nice part about the second part of the question is also looking at physical activity. So it not only do symptoms, because it also asks, how active are you now? So if you're less active, you get lower score. And if you can do less, like for example, I can't run 30 minutes without having pain, you get a lower score. So the nice part about that is it looks both at, you know, pain and symptoms and physical activity. So the nice part when you put that score together, because you can have a patient that has, let's for example, have a very low symptom right now because they don't do anything. And that will be sensitive in the score, versus when they start doing things, the symptoms goes down, but the kind of the grading of that goes into the Visa score. So in that sense, I think it's really, really good. I think it's always beneficial. We use the sum score when we're looking at treatments and research, but I think it's always good to look at those various questions as well when you're looking at it. There is some problems when you're looking at the upper part, right? How people change beyond 90 out of 100, which score is 100, because you can have 90 even be fully healthy because you're not active at all, even if you never have symptoms. So you need to just know those things. There are also other questionnaires that you can do that are more generic for the lower extremity and for lower extremity activity scales, lower extremity functional scale, I think it's called, and other things too. But we use a lot of various scales. We also use the Faust foot and ankle outcome score that looks at the same as has been done for the knee, that look at pain, symptoms, activity, quality of life, and sports. And we tend to use the quality of life for that one. So I think there's a lot of various things, but I think, again, you want questionnaires that look at pain and symptoms specifically for Achilles tendinopathy. You should use the Visa one. But then if you're interested in very other activities, there are more broader, generic ones for the lower extremity.
Great. So it's about picking what are the key things that this patient's interested in, what does the patient want to get back to doing, and finding the tools that are going to help you get at those particular things.
Yes. And maybe I want to add too, if I'm allowed to add it now too, I think that the other thing that we're looking at too is a lot, and I think there's been a lot too, going from the biology of the tendon to, we look a lot at fear of movement. So we use Tampa scale of kinesiophobia. And the reason we use that one is because I've used it in my research since I started since my PhD, just a few years ago. And we've used the same one, the Tampa scale of kinesiophobia. So we have a lot of data, both from Achilles tendon ruptures and tendinopathies, and there's a lot of data to compare with. So we use that one to kind of look at more of fear of movement in general and how that affects us, since this is a pain condition. We use things like pain catastrophizing scale as well. So there are other various things that you might want to be interested in.
And are those pain catastrophizing, fear of movement, are they issues for everyone with Achilles tendinopathy, or are they issues that you're going to be particularly, or questionnaires that you're going to particularly target for particular patients at certain times when you think that it might be a problem?
I think that's a great question. And not to give everything away, but we are hopefully submitting a study fairly recently soon to try to look at the various, that not everybody is the same that have Achilles tendinopathy. So we're trying to look at, are there more people, is there a certain group, for example, that have more fear of movement, that's more of their problem? Do we have people that are more loading a lot? Is that more of their problem? Are there other personal factors? And we know that metabolic factors affect tendons, right? So we're trying to really, with that research, try to guide and then help clinicians to understand that this patient might be more in this group and this patient might be more in this group. And then you can, you know, modify your treatment. My recommendation today is you can always start the baseline with the patient, and maybe you don't want to do the TSK or you do want to do that. But I think that if you're following people over time and really are aware that there might be other variables that limit them, then you can start guiding your treatment in all those directions.
Great. Let's move on to management and rehabilitation, return to sport, those big issues. When I was learning about tendons in physio school, it was essentially do Håkan Alfredson's program. If it's too easy, give them a backpack with weights. It's all eccentric, eccentric, eccentric. What's the update there? Eccentrics, is that still the deal, or are we moving? What sorts of exercise modes might we be looking at here?
So I think there's, oh, this can be a long answer, but I think this is it's really exciting to think about, right? So I think, first of all, it's in a historical perspective, it was that we thought it was tendinitis, and we were very concerned with the pain and the inflammation. So we were really worried about loading these tendons. And then, and Håkan was excellent. He was in the forefront of that too, is looking at, okay, maybe it wasn't an inflammatory, it's not an inflammatory condition. So then we're like, okay, we don't have to be as worried about the pain. So maybe we should load this tendon. And we went from not loading, really worried, to start loading them eccentrically. And all of a sudden we're starting to have really, really good effects. And I think that was like the big shift. And basically what happens is a tendon needs to be loaded in order to recover. A tendon, it's negative for a tendon to be immobilized, and it can be negative for a tendon to be loaded way too much. So it's a balance in between there. And if you have an injured tendon and immobilized, it could be even worse quicker. So we really need to load the tendon. A tendon needs this medication in order to know how it's going to heal. So I always say the loading is the medication. The interesting part with loading, though, is that in general, the muscle can go eccentrically, concentrically, isometrically, but that load is in series with the tendon. The tendon doesn't really know what the muscle is doing. All the tendon knows is the amount of load that is transferred from the muscle to the bone, and that will load the tendon. And if you look at healthy research, there's been some really good studies done by Aram Patsis, I think. I probably butchered his name or her name. But that's, you will really look at, and other people have looked at the healthy tendon. So what we see is the tendon responds best. It probably with heavier load that strains it more. So you need to pull this tendon apart more and over a period of time. So slower, pulling it apart longer, that has been shown to the tendon respond by getting more resistant to load and maybe getting bigger. So those are the things that kind of, if that's what you're trying to achieve, and it seems to have the really good benefit also for the injured tendon.
Now, what about isometrics? I remember reading about isometric training relatively recently. Where does that sort of fit into the tendon rehabilitation picture?
So I think that it's, so there's been a drive of now we have to do the isometrics with a tendon and things too. And my bias, and I think is supported in the research too, is that we need to load the tendon. What the muscle is doing how it works doesn't really matter as long as you can get load to that tendon. So if a person, for example, the problem with purely eccentric was that people could kind of do the eccentric movement and they were just dropping, but they weren't loading the tendon. And some people were starting calling it eccentric stretch exercise and things, which kind of goes totally away from loading it. So if you have a patient that can't do the eccentric, will do the kind of resisted, they're not getting that load. And then maybe they have difficulty going up concentrically too, then you can load it the same way, just isometrically, just having that holding it. You can get the same kind of strain through the tendon. So, and you can get it, if they can't stand, you can get it with a TheraBand or you can load. So I think as a rehabilitation specialist, it's not as much about the muscle contraction. It's about finding a way for getting that patient to get that load to the tendon that the way you want it to get. And I would say for some people that have maybe more pain at the insertion by the heel bone, they get a lot of pain when they move out of neutral and into plantar flexion, or when they are in a dorsiflex position. So sometimes they have a hard time they have a really short arc of movement that is pain-free. So then maybe you just want to have them hold that to kind of get the muscle going and get the loading. So I think using your clinical experience and things to understand, you're trying to get load to that tendon and then find a way of doing that.
And I think some of the isometrics research came out of neuroplastic changes. And so what do we know about the relationship between tendon pain and brain changes?
Yeah, so it's a really, I mean, there's a lot of research, and I'm by no means an expert on the brain. I only think their tendon exists, but what we've seen is that there are definitely some interesting things. So if you can look at, for example, if you cause tendon pain, and people have done that with research, you immediately see that there are changes in muscle recruitment. So there are changes in muscle recruitment on the local level if you induces pain, like you decrease the use of the gastroc and you might use other muscle to kind of get the same movement. And then Eugene Chang and Cornelia Kulig did a really interesting study looking at people that had Achilles tendinopathy but no longer had symptoms, but still had tendon changes, because we can have, even when you recover the pain, the tendon might not have fully recovered. So their tendons were more compliant. The mechanical properties weren't fully recovered on the injured side. And what they saw, despite you not having pain, that the recruitment was altered. So the body is trying then to compensate, and it might be the brain changes and things too, for that more of elastic tendon by recruiting other muscle, but also trying to recruit the gastroc earlier to kind of get a tension in that tendon before it gets to be loaded. So the body is trying to compensate. I mean, and that's what's so exciting about working with humans, right? Because the body tries to compensate, and compensation is good in a lot of ways, but sometimes to compensate, you want to maybe make it go back to the way normal is as well. So there are definite changes. A lot of people have also tried to look at central sensitization, more of the pain area too, but that does not seem to be a big issue from the Achilles tendinopathy. It's more of a local sensitive changes to pain, but less of a central. But definitely we can see some mechanical changes in recruitment, which I think is really interesting.
So let's talk rehab. So we're going to zoom out a little bit and look overall at rehab first. Can you share your guiding principles to Achilles tendinopathy rehabilitation, please?
Yeah, so my guiding principles for that is to really, there's like two major things. That the Achilles tendinopathy, or tendon in general, needs loading. That's their medication. So that's where you start with a tendon. So you need to load that tendon. And we know that. But we also know that overloading is kind of the injury, right? And underloading is it's negative as well. So the guiding principle is really then that you want to continue to push the loading to get the recovery, but you want to be really sensitive to where the balance is, right? So it's very much of going step by step in the rehabilitation. So you never want to take big jumps in loading, and you don't want them to stop loading either, right? So there is the tendency sometimes, oh, I did the loading and it hurt, so I completely stopped. And then they have underloading, and then they go back to try to load again, and then they have overloading instead of getting this path in between. And you see that for Achilles tendinopathy patient, a lot of, I think you're all probably seen it if you've had the patient. It's like, yeah, I used to run and those things, and I got Achilles tendon pain, so the doctor or I decided to rest. So I rested for 3 or 4 weeks and I had no pain, and then I started running again, and the third run I had pain again. So it's that shift back and forth. So it's kind of controlling the overload loading relating to maybe to sports and physical activity, but also loading the tendon so the tendon gets the medication it needs to kind of recover.
So let's go to the holy grail of loading. How do you do that? How do you start a loading program? How do you progress a loading program? How do you know where to start a patient or an athlete with Achilles tendinopathy?
Yeah. So I think that the biggest thing is you need to start instead of worry about where to start. So what we use for tendon, and that was from Roland to me, who was my advice to use for patellofemoral pain, is we use the pain monitoring model. And the pain monitoring model is where you're talking about the numerical pain rating scale from 0 to 10. And we say that 0 to 2 is acceptable pain to have, and or is safe, and up to 5 is acceptable pain to have for the tendinopathy. And really talking to the patient about that to understand where their pain level is and how to load within that kind of safe zone. I think that's a really good way to start. And sometimes we get criticism, and sometimes we get criticism on Twitter too, that 5, I don't believe 5 is the right, maybe 4 is better. But I think the point is not if it's 4 or 5. The point is, if you don't load it and allowing some pain, it's going to be detrimental as well. So you need to start with the person that you're working with to figuring out what their level is. And you always get this other criticism is from the patients is, well, it's not going to work maybe because I have really high pain tolerance. That's the other question too. I always say it works really well on those with high pain tolerance, because it seems to be somewhere around 5 as you go from it hurts to I. It really hurts. So we start to kind of looking at that it's okay to load it. Don't be worried about loading it, but don't go way beyond that either. So that's kind of the first thing that's really discussion. And then in order to understand this, we add the training diary to that. So I have a training diary for all of them, because you need to document what they did, what their symptoms were, and you can't just document it momentarily in the clinic, because that's like a snapshot. You want to have it over weeks. So I always start, okay, we're going to start this exercise program. We're going to load this, try to find a level that we think is within the pain monitoring model that works for them. And then they do the exercises daily, and we can discuss why daily or not daily. But for right now, they do daily exercises, and then write down in the training diary how they feel in the morning, other activity they're doing. And then when they come back to me, that's when I can really start looking. So nobody wants a home, home exercise program or I was going to say homework to write down the training diary if you don't look at it. So you need to look at it, but you bring it up and you can put these training diaries next to each other. That's when you can start seeing patterns. Well, look, every Monday you're hurting more because you cut the lawn every Sunday. So that's fine. Just realize it might not be detrimental, but that's what it is. So don't get discouraged every Monday, or you seem to be going lower in the pain level now for a whole 3 weeks. You've been going from generally 4 to a 2. So now we can increase the program and your activity. So one of the things that patients tell me that they find is the most important thing that I say is, my goal is not for you to be completely pain-free. My goal is for you to keep the pain same, and I will push your capacity. I will push your capacity of doing other activity. I will push your capacity of doing heel rises, because then it's not so much, so the pain level stays the same, all the other things are going to increase.
And when we talk about load here, what is load? Is load just the strength exercises? Are you allowed to go running? Where do you start with that?
Man, you're asking some hard questions. I don't know what people sending these questions in. No, I mean, that's really hard, right? So all of it, and I think that's some of our research is going in that direction with some of our collaborators too, to really, we get to focus, you're going to do 3 sets of 10, and then one person is working all day running around, another person is sitting, right? So it's that whole, what is the load and how much load can the tendon tolerate? So I think there's a lot of variability with that too. And that to me was why the training diary works well too. And nowadays people usually start putting down the step count for me. So I've been walking this many steps or those kind of variability. And I think that is another way to be able to measure it optimally. Maybe we will have sensors in shoes and kind of looking at it. But we really try to document it and try to find the way that we can do for that person. So if I'm working with a runner, we know that the tendon load increases up to 9 to 12 times body weight with running. Faster running is higher load on the tendon than slower running. We know that running on forefoot is heavier load than to be a heel striker. So we kind of know various things. We know a fair amount how to load the tendons. You can count how many steps somebody's out running, but we kind of test either time or by distance. And then we're trying to start guiding where where the activity level be. And we don't always know when we start, but since we have the training diary, we can see, oh, we seem to be a little bit too much here. So now we need to change it. So for example, somebody can maybe run for a little longer period of time at a slower pace, then the same amount of load might be running faster capacity, like 90% of the max speed for a shorter period of time. So we start trying to vary those variables that we know are affecting the load on the tendon, but we don't have 100% answer, but you talking to the patient, you can kind of start figuring out. And again, I think the training diary will help you when you start looking at where the patterns are.
Now, you also mentioned we can talk about daily exercises or not daily exercises. Let's go there. So daily, not.
Yeah, I think it's really interesting. So, you know, the heavy slow resistance training came in too from patella tendinopathy and for Achilles tendinopathy, and that will be doing really heavy. I think they do 3 times a week, and they compared it to ultrasound protocol. And really, there is no differences in that. I think the main thing was that people who did the 3 times a week was more satisfied, but sometimes I don't know if that has anything to do that relates to the tendon more than a person is helping me 3 times a week versus those things. So I think that you need to start thinking about doing it. We do daily exercises, and my reason to do daily exercises is I think the tendon needs enough load to kind of move forward. If you're doing really heavy at a gym, maybe you can do 3 days a week, but usually if you do it at home, their loading might not be so high. So then I try to compensate by doing maybe more repetitions. The other things are much more pragmatic why we do it every day, because if people do it every day, I'm expecting them to do it 5 to 6 times a week. And they seem to remember to do it every day. I don't know about you, but if somebody tells me I can do it 3 times a week, it's so much easier for me to continue to forget it instead of I needing to know to do it today. So that's my pragmatic things. I just want you to get in the habit of doing it just like brushing your teeth. And people actually seem to really, from all the training diaries, people like that because you get in a rhythm and then you don't get off the rhythm. So we usually start with daily and kind of move forward. However, when we go into the really heavy, then we're starting to decrease. So when we're like in the later phases, a lot of times maybe they do heavier 3 times a week. And a lot of that varies along with the patients too. We're doing our research study now, trying to, with the various phases that we have in our treatment. And it's, you know, you have to work with the patient what works for them basically too.
And when you talk about heavy resistance training, what sort of RM or repetition maximum are you using?
Yeah, so we tend to, for the Achilles tendinopathy, we kind of push it up, and it depends on what the weights and things are. What I can say is that we usually try to get anywhere from 3 sets of 5 to 3 sets of 10. So that kind of, you can looking at how heavy they can do for those. I do want to say though, that for a while, I've done a lot of mistakes in my career. 2 mistakes was, first, I wanted to make sure that people were working the full range of motion. I thought that was very important when we started. And if people go too far heavy in really heavy weights, too deep in dorsiflexion, they start to develop insertional symptoms. So you got to be really careful that you control that and don't do too heavy so they kind of bounce down. So that's one thing. And the other thing was, you try to increase the weight and increase the weight. And I saw for some people, depending on what they're doing, it seems to be a max level for what is good for the tendon to do repeatedly over time. And I think that's also been shown when you're looking at animal studies and those things too, right? So for a lot of people in kilos, I think we got up to people doing 40 to 50 to 60 kilos. That seems to be doing several repetitions, and beyond that might be too heavy, right? So then you do less repetitions. I got to say though that the calf is really, really strong, because I tried to, in my thesis way back when, I was set on, we were going to test it at doing 1 repetition max for the calf. That was the measure we were going to do, not heel rise endurance. However, I got people that can lift 5 times their body weight if you put them in the machine. And that's just not feasible for neck and shoulder and all those kind of things. So I kind of gave up on that.
Fair enough. And we're talking about single leg exercises here, right? Not bilateral.
Oh, great. Thanks for asking that. Yes. So we really try to work on single leg exercises, basically, because otherwise you might as well, if you're doing 20 pounds with bilateral, it's going to be harder just to do a single leg. So we want to try to get them single leg. There are times when you might want to do bilateral if they can't do a single leg heel rise without weight. You do, but we start with bilateral all the time. That's our first exercise because we do that as a warm up instead of anything, right? So you're going to do 3 sets of 10 bilateral as a good warm up. But also patient that might not be able to load 100% body weight, then you can actually do bilateral and try to get them more and more loading on that injured side. You can have a scale under the injured side and the box on the other, so the same level, and see how much weight they're loading and those things too. The anti-gravity treadmills are great now to really know how much load you're doing and be able to progress heel rises. And we use that, and that's really exciting too.
And I guess the other thing is not to forget about the uninjured side, and that you are focused on the side that's most symptomatic, but quite often people might have bilateral symptoms. It might just be that one's worse than the other. So you get focused on the sorer side, but it's probably important not to forget about the other side too.
Yeah, I mean, you bring up really good points there. I mean, in our research, we never talk about an injured and uninjured side. We talk about most symptomatic and least symptomatic side, because they're very rarely, well, I would say half of the patients have bilateral symptoms and half of them don't. But also 40% of patients with Achilles tendinopathy develop pain on the previously uninjured side. So when we do see that people might offload the injured side and then load more on the uninjured side. Now I'm getting lost in my words here. So you can kind of see those things. So we really, since we're doing the single leg heel rises and you want recovery in between the sets, we always make them do the other side as well, and they might as well.
It's perfect recovery.
Yes.
Now let's talk about plyometrics. How do you start to bring plyometrics? How do you transition from the strength training, that sort of pure heavy strength training, to plyometrics? And then we'll get to the return to sport part as well. But how do you make that transition? When is it a good time to start plyometrics? How do you know when the athlete or the patient is ready to start plyometrics training?
Another excellent question. And I think that, we got to remember when we're talking about the heavy, slow to get the tendons tolerance to get stronger and bigger, we also need to think about that the tendon needs to tolerate fast loading as well. So you need to train that part as well. Now, what we start in fairly quickly, we start to do quick rebounding heel rises to try to get that speed in. And we do that when they're starting to recover kind of before anything like jumping. So that is our first measure of kind of plyometrics. So if you can do quick rebounding heel rises, and then when they can tolerate that, the next step then will be to do gentle jumping, bilateral jumping, and those kind of things too. We try to do that at the face when they can walk without difficulty, when they are kind of gotten into the exercises, all of those things are working well, and the walking is not a problem, then we're starting with the quick rebounding heel rises as well.
And what do the quick rebounding heel rises, is that just standing on the floor and doing as many single leg heel rises as you can quickly, or what does it look like in the clinic?
Yeah, so what it looks like in the clinic, it's basically you're standing on both legs, but you're leaning a little bit more to the wall, and you're quickly kind of coming up and down as a heel rise, but you're kind of bouncing a little bit more. So just like the pre-jumping, pre-hopping movement. So that's what we call the quick rebounding heel rises as well.
Okay, so quick rebounding heel rises, then you're starting to move into single leg, and then you get into jumping, hopping stuff. So, and that's where I interrupted you. So keep going.
Oh, yes. Yeah. So then, and we are working on a study, hopefully that will come out soon too, that you can start putting in what activities are, so you can actually put in and look at what activities are progressing to the load in the Achilles tendon. We know the heaviest load is actually for probably what you do in the clinic is single leg hopping, like jumping rope on the single leg is one of the heaviest that you can do for the Achilles tendon. So just know that that's on the upper end, similar to running or running fast as well. So when you want to start with other things, you can start working on bilateral kind of movement jump, just regular jumps, jumping up and down, jumping down from boxes, doing bilateral jumps, and you decrease the load, working side jumps, all those kind of things increases the kind of the plyometric ability for the tendon too. So start using, and I think it's fairly similar what you're looking at when you're working with knees or ACLs, looking at the various types of jump. But just be aware that the single leg jumping rope on one leg, the hopping when you just kind of bounces up and down, is one of the heaviest loads for the Achilles tendon. And the other thing too, to kind of think about when you're looking at the plyometric, I've worked a lot with elite athletes, like you're talking about track and field athletes that do a lot of really heavy plyometrics. So sometimes we do that in soccer too, jumping up on boxes and things that I don't even want to try. What we found there too, when we're looking, and it kind of comes into the return to sports a little bit too, but what we realized too is that you want that really heavy training for somebody like, for example, as a high jumper and things. And what we kind of found, it was better to do a really heavy program with plyometrics one day and get recovery days than try to do a little bit every day. So I think that's really important too.
Yeah, again, and that's fitting with those that I really needing to have knowledge of training progression, loading principles, and training design. And I think if you're not feeling like you're particularly strong in that, then work with a coach, work with a fitness coach, with an athletic trainer, and get some help on that side.
Yeah, and I think that's very, very important, is that, a lot of times we get athletes, I always work with the coaches and people that's more closer to that too, because I can give you knowledge of the tendon, this is what I need, this is what I want you to do, but I'm not going to prescribe because I don't know your training, and we need to work interprofessionally when it comes to those things. So I work a lot with the running coaches or all the other coaches to really kind of design it, because I'm really good at understanding the basics. I do the research, all those kind of things, but I'm by no means going to be a good trainer for somebody to get back to be a high jumper or whatever.
Now, one of the other things people might be a bit concerned about is this notion of Achilles tendinopathy then progressing to Achilles tendon rupture. So if you've got someone with tendinopathy and you start progressing to these higher load, these rebound type loads with plyometrics, how likely is it that someone's going to jump off something and rupture their Achilles tendon? Do we need to be worried about that?
So the one thing that I say to my patients when they come in the first time, when a lot of them have especially some of them have a lot of fear, is then you talk to them, and a lot of them are very fearful to have an Achilles tendon rupture. And my first thing, and I want to preface this by, don't ever say, oh, never or always, but somebody with painful Achilles tendinopathy do not rupture the tendon. It seems to be that we've done studies on Achilles tendon ruptures, we've done studies on Achilles tendinopathy, and those patients do not crisscross. So it's not like Achilles tendinopathy and then X number of people develop rupture. So having said that, of course, I've had one or two patients with Achilles tendinopathy that has ruptured, but it seems to be that those are not the same patients. And probably this is my theory too, is that you have the pain is actually altering recruitment. So the pain is probably protecting you from loading so high that the tendon can't tolerate it. So, and I think that is, and I'm going to go into some speculation here too, but we kind of see that, and people with rupture have not had symptoms before, but we do think that they have tendon changes. So maybe they have a tendon that's not as strong as it should be, but they don't have any limit in loading it. So those kind of things you need to consider those things. I think that's really, really important. A lot of the athletes that you've seen, sometimes they talked about, they had Achilles tendinopathy. This used to be way back, and they got cortisone shots, and then they had a rupture. And so the cortisone shot has been considered increased risk of rupture. I'm wondering now, the more I'm working with it, was it that the cortisone was actually limiting the pain? The pain was completely gone, but the tendon structure was not healthy enough. So now they were able to load it, and now it ruptured too, right? So I think you need to put those things together. So I'm not worried about that when I'm starting the plyometric program. That's not my worry. However, you always need to progress. You don't go from not having done any jump to doing 500 single leg hopping on that. You just don't do that. And as long as you take small steps, you're only going to fall back a little bit, versus if you take a big step, that's when you get in really trouble. I think that goes with everything in life too.
Yeah, and again, we come back to the concept of load management. So let's move from plyometrics to then return to sport, which is often the thing that not often, it is the thing that the athlete's most concerned about, is most looking forward to, and perhaps most scared about. And coach might be on your back about when can this athlete come back. So let's start with your guiding principles for return to sport, Karin.
Yeah, so and I've been on some other meetings, on Zoom meetings. I've had some great discussions about these things too. So I think my guiding principles, and a lot of times it's easy for me, a lot of times I work with individual athletes, so I can really guide a lot of those various things, but the guiding principles kind of never change. And we use the pain monitoring model to understand the amount of load. We try to have as much knowledge as we can about the various activities and heavy loading they are. So we look at the pain level during activity, and then we always grade the pain level the next day is very important, because you can feel really good when you're doing it, but it's the next day how you tolerated it. So I never give an athlete the ability to go out running and then run more if it feels good, because it's always going to feel good and they're going to do it. So we say, okay, you're going to run 2 miles today at 80% of your max. I want you to grade the pain level when you're doing it should not be above, you don't want to be above a 5. I want to grade that. And the next day, it should not be above a 5 either in the next morning. Sometimes maybe 5 or 6 in the morning, but it shouldn't go higher. So those are the 2 things that I look for. The other thing that we started to look for is we use the Borg scale of rating of perceived exertion, but it's not perceived exertion for your breathing or that capacity, because a runner, for example, running 2 miles, they don't even feel tired, but it's a rating of perceived exertion of the Achilles tendon. And the reason we started adding that in is because you can, it's really hard to talk about the other capacities, especially with athletes, but if they start focusing on that, how heavy do you think that activity was for your Achilles tendon? Then you separate that out from all the other things that they need to accomplish. So for a runner, they can say, for example, yeah, that was a 5 for my Achilles tendon, but for their breathing in general, it was like the lightest running they've ever done, right? So we need to kind of guide that too. So those are the guiding principles. And the other thing, the third, fourth thing, maybe whatever it is, it's getting late here, is the recovery day. So from heavy loading activities, so the Danish group under Michael Chair and Peter Magnuson, they've done a lot of research looking at recovery and tendons. And what you can see, for example, if people were running like a marathon and you're looking at the recovery, you can see it took like 72 hours to have a net collagen synthesis of the tendon. So we're using that principle that maybe a tendon takes more 3 days versus muscle takes shorter time. So when you're starting with these return to sports, heavy activities, they're doing it 1 day and then they need 3 recovery days before they do that heavy activity again. And activities that are light levels, like the daily exercises or biking and those things, they can do every day. So that's kind of the guiding principle to kind of progress so you can load. You might have more pain, but then you need to recover before you do that again. So you don't get that cumulative negative effects that kind of come back into the overuse.
So let's just recap those. It was pain monitoring, recovery days, how heavy the training was for the Achilles specifically, and then did I miss one?
No, I think that's pretty much it. Yeah. And then we use the training diaries to kind of follow it too, right? To really look and see how it changes over time.
And then can you just recap what that specific question was? You talked about the Borg scale for the Achilles. How do you frame that question, and how do you train athletes to be able to answer that correctly so they stop thinking about how hard the session was for their breathing and they think about how hard it was for their Achilles?
Yeah. So again, we're really talking about, and I think a lot of it, I start talking about this actually really the first time I meet them, because when they have a lot of pain, people are much more responsive to kind of understanding these things too. But it's really to understand that for everything that we do, we challenge the bodies in different ways. And depending on what the athlete is, they can say, for example, you can run, but running uphill is harder, or kind of differentiate by those kind of things too. So we really want to know, how do you perceive it? And the main reason I tell people is that if you rate it, me running 2 miles is not going to be as a marathon runner running 2 miles. So we need to start differentiate this. So I don't guide you based on my experience. It has to be guiding you based on your experience, but you need to understand that experience in my mind relates to your Achilles tendon.
Yep. So it's from 0 to 10. How hard was that session for your Achilles?
Yeah, so it's the Borg scale. It's a Borg scale, or perceived rating exertion scale. So that goes from 0 to 10. 0 is nothing at all, and 10 is very, very strong.
let's talk return to sport criteria. We've got in our last 5 minutes, let's talk return to sport criteria. So I want to come back to the 2 clinical criteria and ask you for your return to sport criteria for the runner, say the person who wants to run a half marathon.
Yeah, so, and we have, and Patrick Corrigan was my PhD student and did a lot with the running stuff that we have, and we have data coming out too. But what we did with his research was really to look at people that were back at running and what kind of criteria related to how well they were running and were they keeping a normal stride and how well they were doing. And one thing that really comes out as a really good test is the hopping test. So have them do 10 to 15 one single leg hops and looking at the pain with that. So that if for starting to run, that should not be more than a 1 at the most, maybe up to a 2 when they're doing it standing right in the clinic. I think that's a really good guiding. If you can't do that, you should not go out running, because the running and the hopping is the same loading, right? And we see that if you have more pain, then you're going to start offloading and you might causing more problems in other areas as well. So that's a really good guiding thing to have. The other thing is sometimes we do pain on palpation. We also want the strength, the calf strength, to be what we call normalized. A lot of times we see what the healthy side is and we want them to be normal. Usually the calf muscle endurance and strength is not that big of a problem if they're doing the rehab, because they do heel rises for rehab. So usually that comes at the same time. But those are like really good clinical pearls to follow.
What about another clinical scenario, a striker in a soccer team? What sorts of return to sport tests are you going to use with her?
Yeah, so then when you have for other sports too, it's going to have to be the more specific. Again, we're using the same things, the hopping and those things works as well, right? The biggest issue too then is also to do the progression that we will do with anybody. So there is a lot of general, like I worked with sports team, right? You do the general thing. You need to be able to run forward before you can run and cut. And if that doesn't cause any pain above a 2, then you need to be able to run and cut. You need to be able to run in your soccer shoes, like your football shoes, and the shoes that you're using to be able to do. So we use the pain guiding, and we do progressive, usually then on the field. If I'm not on the field with them, I will give them the same thing. Okay, today you're going to do back and forth so many times, and then you're going to do X number of times running and cutting, and then I want you to come back and tell me what the pain level was that day and the next day, and then we can continue those things.
Great. Love the clinical pearls. Thanks, Karin. I want to finish by asking you to take a bit of a look over the horizon. And what do you see when you look over the horizon in terms of the next steps and the evolutions in managing Achilles tendinopathy, particularly from the rehabilitation perspective?
Yeah, I think that the biggest perspective that I see, or what I'm really working towards, so it's biased for me, obviously, but I think we need to start thinking about who the patient is. Achilles tendinopathy is a term, but it's so much broader than that, right? So we do have different classifications of patients, and we need to start looking at it holistically. So we talked about it here. We have symptoms, we have function, we have tendon structure and things too. And the next thing is going to be the personal factors. I also think metabolic factors is starting to play a role. All those aspects, we need to understand how they're affecting it. And instead of jumping to the next thing, this is what we're going to do now, or this is what we're going to eat, or this is going to measure, I think we really need to start understanding who is the patient you have in front of you and what is it they need of all these factors in order to get them better. And the other thing too, I think we really need to realize that there is getting a quick fix probably not going to happen. This has to take time. So I'm really in the horizon. I'm hoping that it's not too many of the quick fixes, because they tend to not help and we're jumping for. But if you understand how they work and for whom and why, maybe we can reap the benefit instead of just kind of jumping from one thing to the other.
Thanks, Karin. Thank you for a really great chat. I loved the clinical pearls and want to thank you so much for sharing your wealth of knowledge from research and also from the clinic.
Thank you so much. This is really exciting, especially for being home all day too. It's nice to share and be able to talk about what I really feel passionate about. So thank you so much for the invitation. And these JOSPT Ask, all of them has been fabulous. So great job, Claire.